So most of you grew up in a tropical place, and we can have the next slide. Tropical infections are infectious diseases that occur either uniquely or more commonly in tropical and subtropical regions. And they're more widespread or more difficult to prevent or control because of the conditions that exist there. Because of the heat, because of problems with sanitation, because of large numbers of people. Next slide, please. So here's the tropical belt. I'd love to know where everybody's from. Are most of you from Nigeria? Show me your hands if you're from Nigeria. Okay, great. Well, I'm going to let you tell me, besides Nigeria, quickly, tell me where else you're from. Ghana? Is that it? Just Ghana and Nigeria? Oh, okay, that makes it easy. All right, go ahead. So in the 20th century, going into our century, the 21st century, we've seen a resurgence in different kinds of infectious diseases. Some of them are newly recognized, some of them are known, some of them are in typical places, some of them are in atypical places, and we're still looking at a mortality at the beginning of this century of 26%. So a quarter of the world still dies of infectious diseases, so it's a serious problem. Yeah, and here are different diseases that we can look at. So we're going to talk about some of them today. One of them is malaria, of course. It's an important disease. One is typhoid fever. We're going to talk about chikungunya. We're going to talk about Ebola. We're going to talk about yellow fever. We're going to talk about dengue. And anything else up here that I've noticed. So I don't claim to be an expert in tropical diseases. Thankfully, there's a lot of information today available. What I need to say before we go on is that everything changes. Tomorrow, someone may come up with a new treatment. Next month or next year, there may be a new antibiotic. Next year or in 2 years, there may be a new resistance to the antibiotic. So we have to remember that it's very important to keep up to date with these things. What I'm giving you is a base, but you're going to need to continue to look at it. So why do we have infectious diseases? What are the different reasons why, as I said before, they're so common in the tropics? Maybe it's population, urbanization. It's still related to agricultural and animal uses. Sanitation's got to be in there somewhere. And modern transportation. Give me the next slide. So people are flying, boating, moving everywhere. And epidemics for centuries have moved through transportation. So one of the first cases of yellow fever, an epidemic in Philadelphia, was in the late 1700s because of a boat that brought it from the tropics and brought it to Philadelphia, and people came off the boat and the infection came with them. So these are the things we're going to talk about today. We're going to start with Lepidus Furiosa, which is here. Go on to malaria, talk about dengue, enteric fevers, different fevers not included on this slide. Cysticercosis, yellow fever. I won't get to TB today. You should be. How many of you heard lectures about tuberculosis here at your medical school? I would hope so, yeah. TB is a big problem here, and so you're going to get lots of good training about tuberculosis in Ukraine. And then we'll talk about helminthic infections. So what do you think? What's the first killer? First killer now, infectious disease. Malaria, yeah. How about the second? Whoops. No, this. Helminths, yeah. And the third, any guesses? Cysticercosis. Okay? So if you don't know those things, then we're going to talk a little bit about them. All right. We're going to start with Lepidus Furiosa. It's the most widespread zoonosis in the world. Did you know that? It's It's here in Ukraine. A couple of years ago, one of my coworkers had her father-in-law, her mother-in-law called her, said that her father-in-law had been taken to the hospital. Within about 24 hours, he died of severe Lepidus Furiosa. So I had a contact with him because of that illness, because of my friend. 7 to 10 million people are infected annually, and of those, 1 million are severe, and 59,000 deaths. So this isn't one of the biggest killers, but this is the biggest infection transferred by an animal in the world. And here are all the different reservoirs, tons of them. Lots and lots of different kinds of leptospirae, over 100. So I didn't bore you with the whole list. Go ahead, next slide. And where do we get it? People who work in occupations with animals, of course, get it. People who are exposed to sewers. People who do recreational freshwater swimming. This man swam in his village, and that's where he got his Lepidus Furiosa from, the man that I just mentioned. So how does it get in? It gets through cuts in the skin, mucous membranes, or even intact skin if you are in water for a long time. I don't know that period of time. I can't tell you, okay, if you're in there for 20 minutes, you're fine. If you're in there for an hour, you're not fine. But if it's in the water, you can inhale it, you can bring it in. So it is a real problem. Okay? Next slide, please. So these are the clinical manifestations. Incubation period anywhere from 2 to 20 days. Fever is the symptom that we're going to talk about today. Lots and lots of fever. So tropical illnesses usually present with fever. And in the leptospiremic phase, you get myalgias and headache, nausea, vomiting, abdominal pain, and conjunctival infusion. That's a little bit out of the ordinary, so that can help us to know. And then this immune phase where the products of the leptospira, the antitoxins, the antibodies to it, again, start to cause problems with meningitis and uveitis and rash. Wells syndrome is the name for severe Lepidus Furiosa. Anybody ever heard that name before? Haven't heard this at all, this disease, right? So at any rate, same kind of phase, 3 to 7 days, and these guys get really, really sick. They're jaundiced, they get acute renal failure, hemorrhagic pneumonitis. So it is you'll see the same pattern over and over again with tropical illnesses. Many of them will present with fever, they'll present with abdominal symptoms, and they'll present with hemorrhagic symptoms and jaundice, okay, and renal failure. So basically, some of the same things, and it's difficult to know what you're dealing with. But this one, again, is worldwide. So you're not going to see malaria in the villages in Ukraine, but you'll see this disease. All right, and you can remember it. If you know it, if somebody shows up in your hospital with those symptoms, and yeah, she talked about that, you can tell your supervisor that that's a possibility. So how do we know? We know by culture, we know by antibodies, we know by serology. That's the main way. Got to detect the antigen so we've got to guess that it's there in order to look for it. Okay, and how do we treat these people? Thankfully, there are antimicrobials that are effective. The other thing that you'll see with tropical illnesses, is the statement: supportive and symptomatic treatment. So we're going to go over that in a couple of slides. What do we do for people when there's no specific treatment? Well, for this illness, there is mild forms: doxycycline, amoxicillin, erythromycin. Doxycycline is a very, very helpful drug in many different illnesses, as well as erythromycin. So you can almost say, if you have no idea what it is, start giving them doxycycline. You just might hit the right problem. Moderate to severe forms, I don't know if my friend's father-in-law got anything IV. I'm sure that he did. He lived very shortly. And the next page. this is an interesting one. So if you find out, you've got to think about protective clothing. You've got to think about controlling your access and your exposures. And this is a really good idea. So just 200 milligrams of doxycycline once a week can be prophylactic. If you're going somewhere, if you're taking a trip, if you're going to be in water a lot, and you've heard Lepidus Furiosa is there, and you can take a dose of doxycycline. So as you may remember, doxycycline is one of the common drugs used for prophylaxis of malaria. The dose is 100 milligrams at a time. So just one dose a week of 200 milligrams would be protective against Lepidus Furiosa. Have no vaccine for this illness yet. Okay, we'll keep going. Now we're to malaria. So I would ask how many people here have seen malaria, but I know if you grew up in Africa that you saw it. So how many of you have had malaria? Yeah, I expected that. So I should call one of you up here and have you do this lecture. I saw malaria. I saw lots of malaria when I was in Uganda. Unfortunately, we had babies die every week. So at least one child died, and often those children died of malaria. So it's a very serious problem caused by a protozoan, which is transmitted to human red blood cells by female mosquito bites. And so the different kinds, you've probably heard of them before. You've got Plasmodium falciparum, you've got Plasmodium vivax. Those are the most common. And those are the only ones that there are drug resistances to. Obviously, the others are less common. We don't have resistance to them. So and they can stay dormant, or they can, again, come out and produce their symptoms. So 3.3 billion people live in areas at risk of malaria. 35 countries in sub-Saharan Africa, 30 in Africa account for 98% of global malarial deaths. And so here are just some statistics. Most of them are in Africa. It's the 5th cause of death from infectious disease worldwide. So, like we said, it's the #1 cause of death from infectious disease in Africa. I'm sorry, I'd forgotten about the other one, about HIV. Yeah. So when you put HIV together with tuberculosis, together with malaria, you have a very deadly combination. Yeah, and there it is. Second leading cause after HIV. Go ahead. I saw that too, of course. So here are the 4, Ebola and malaria. Those tend to cause less complicated malaria, and this is the biggie, the one that causes the most complications, Plasmodium falciparum. Next one. Okay. So, and here are death rates. These are years when there wasn't a lot you could do other than quinine and chloroquine. The drug uses have changed, and you see the decrease in deaths. So we're still talking about a very large number, but compared to the cases and the numbers back in the 70s, praise God, a lot of difference. Yeah. Yes, all our medicines were free, given by the government, stockpiled in boxes, and I remember all those medicines. So patients are asymptomatic for about a week, and then things start. The initial symptoms are nonspecific: fever, headache, fatigue, muscle and joint pain, nausea and vomiting. How many of you remember being ill with malaria? It's not something you forget, right? Not at all. And I'm sure that you probably were ill more than one time. The classic malarial paroxysm of chills and rigors followed by fever spikes, followed by profuse sweating, is coincidental with the synchronous rupture of blood schizoids and liberation of metabolic waste byproducts into the bloodstream. So let's see a picture of that, okay? So here it is. Here are the oocytes. So this is the out of the body development that's going on in the mosquito. Here's the mosquito ingesting the blood meal and then giving it away. So getting and giving, that's the part the mosquito plays, and then they develop in the gut. And here we have the organism going into the liver, infecting cells, and here you have the rupture. And that's where you get the chills and the fever. Okay, so it corresponds with that. And then again, you get the same rupture in the red cells. So people come in, they're very anemic because their red cells are being destroyed, ruptured by the parasite itself. Go ahead. So severe malaria has very serious consequences. Coma, prostration, convulsions, acidotic breathing, circulatory collapse and shock, jaundice, hemoglobinuria, spontaneous bleeding, and parasitemia that can be seen. So here's again the same sort of thing that we were talking about, the hematologic symptoms, the hemorrhagic bleeding that occurs, infarcts, capillary leakage, organ dysfunction, anemia, thrombocytopenia. So it's a very, like I said, Satan doesn't come up with a lot of new ideas. So most tropical diseases in their severe forms have hemolytic complications. And 10 to 20% of these patients die with treatment. Without treatment, it's pretty fatal. All right, so, and here are just the WHO criteria, the World Health Organization criteria, just for your knowledge. Same things that we were talking about. Severe anemia, hemoglobin, less than 7 or 70, as we would say here. And low blood sugar, etc. Okay. So, how do we know how people do? The patients do worse depending on their setting. Obviously, a drug-resistant parasite is going to be a problem. In a host with genetic complications like sickle cell, or with already anemia, you're going to have a problem. Yeah, I understand, and I'm sure you understand that sickle cell trait is actually somewhat protective in malaria. Sickle cell anemia and an already compromised host is going to be a problem. Pregnancy is a factor. That's access to treatment, political stability. You get a case of malaria while you're running away as a refugee, you're in trouble. So all of those things we add up when we come up with a clinical outcome. The symptomatic infection, severe malaria that starts if a patient doesn't have access to care, and eventually death if their disease isn't controlled. So what do we treat it with? Well, before we get there, let's talk about the laboratory diagnosis. How many of you have looked at blood smears of malaria? Ever seen them before? Okay, we're going to look at them today. In addition to blood smears, even small places like my lab at our little hospital in Uganda, in Bundabugyo, had the access to antigen detection by rapid dipstick. So let's look at some of them. Okay, here's falciparum, joy of joys. Next one. Yeah, there's Vivax. There's malaria. Sorry, I think I just showed you another one. Yeah, in the cell itself. And there's Ovale. Yeah. Okay, so people get really good at looking at them. And so one of the standards is looking at the slide and seeing the parasite. Okay? Like I said, in the 1990s, they introduced some rapid diagnostic tests which were able to distinguish between the different kinds of Plasmodium, which of course is very helpful because if in your area you have a lot of resistance to falciparum, and you turn out with a falciparum infection, then you're going to want to treat it with something that is better for that resistance. So here's our drugs. Okay, these are the uncomplicated infections. We gave out a whole lot of this. 1 tablet BID. Yep, for 3 days. That was our major treatment that we used for malaria. Yeah, and then we had patients on quinine. But these are all the uncomplicated patients. Most of our uncomplicated patients we treated with the first. Yeah, next patients are the severe malaria, or patients who already have parasitemia that are in larger amounts. So we used artesunate and we used quinine IV for our severe patients. Chloroquine was the old drug of choice. Chloroquine is the main medication to which multiple strains of falciparum are resistant, and so we don't even treat falciparum malaria anywhere with chloroquine anymore. But it's still a wonderful drug for plasmodium that are not resistant to it. Okay, so how can we prevent it? How many of you have a mosquito net at home? Yeah, we had, in our hospital, we had lots of mosquito nets. They just hung there. They were just kind of wrapped up, and they hung. Nobody ever used the mosquito nets. Nobody ever closed the doors of our hospital. So we didn't do so well with prevention. Of course, I took my malaria prophylaxis religiously, and thank God I didn't get malaria. But it's a hard thing to prevent. And if I lived there all the time, I think I would struggle with taking prophylaxis and with protection. Okay, so that's malaria. Let's talk a little bit about dengue. Has anybody ever seen dengue fever? Transmitted illness, transmitted by the same mosquito that transmits yellow fever. And the symptoms, again, start between 4 to 7 days after the mosquito bite, last for 3 to 10, and usually that's how people get it. So you got this combination of a lot of mosquitoes, a large number of people with no immunity, and the opportunity for contact, bingo, you get dengue. One of my friends had her brother in China. He came back with dengue fever. That's as close as I've gotten to it. So there may have been patients we had with dengue. I didn't recognize it, didn't know it. So it started in monkeys, jumped to people, and originally was minor until World War II. Remember how I said that what's happened is that with all our advanced transportation, our flights here and there, our boats here and there, it all goes round. And that's what happened with dengue. So, go ahead. So there's a picture of a dengue epidemic, children, adults with hemorrhagic fever, and many of them very critically ill. So here are the different, is the distribution of the different viruses. So you've got dengue 1 and 2, mainly in the African subcontinent. And over 40% of the world's population is at risk. So you need to know about this infection. It's endemic in more than 100 countries all over the world. Okay, go ahead. So here are the countries at risk. We don't need to see that one again. Go ahead. All right, so people, again, incubate for about 3 to 14 days, and most of the patients are asymptomatic or have a fever plus a rash. Have we heard that before? Fever and rash, rash and fever. That's what you're going to see. So the classic dengue is fever, a retroorbital headache back here, okay, musculoskeletal pain, and a rash. Leukopenia, thrombocytopenia, and the diagnosis is usually clinical, although serology is very helpful. Who has ever heard of the tourniquet test? The positive tourniquet test in dengue. So what you do is you put a blood pressure cuff on, and you pump it up, check your blood pressure. And then in between the systolic and the diastolic pressures, let's say that they're 120 over 80, okay? You pump it up to 100, right in between, and you leave it there for 5 minutes. You leave it on. Then you take it off, wait 2 minutes, and count the petechiae. Everybody knows what a petechiae is? Count the little tiny bleeding points, okay? If there's more than 10 in an inch, 2.5 centimeters, you've got dengue. There we are again, hemorrhagic, okay? So don't forget, fever, rash, hemorrhagic symptoms, tropical diseases. That's what happens with dengue. So here we are. See all the petechiae on this person's body? Yeah, so it's a petechial rash. What's the other illness that can show up with fever, neck stiffness, a hemorrhagic rash? It doesn't look exactly like this, and we get it here. You need to think about it really, really fast, because these people die fast. Anybody know? Meningitis, yep. So, but it tends to be darker than this rash, but again, it's a hemorrhagic rash. Go ahead. All right, so dengue fever, hemorrhagic fever, again, shock syndrome. They're really sick. Again, they have this positive tourniquet test, platelets less than 100, hemoconcentration, and how do we treat these people? Next one. Not quite there yet. So here are the warning signs, kind of the things we were talking about. We've gone over them. Probable dengue. Here, can't read this one very well. Only I can, I'm afraid. Tourniquet test is on there somewhere. You confirm it with serology. So what's going to happen is they're going to have severe hemorrhagic diagnosis with plasma leakage, severe hemorrhage, severe organ impairment, and so what would you do for somebody who's leaking stuff all out into their lymphatic system, into their tissues? What would you do? What's going to happen to their blood pressure? So what do you need to do for these people? What's supportive treatment? Add fluids. Gotta add it. Gotta aggressively hydrate these people. Supportive gear. Okay? So that's the only thing we can do for patients with dengue. There's no vaccine. There's no antibiotics. The only way is to treat supportively. So fluids are very important. Occasionally antibiotics if a patient gets a related bacterial infection. Antipyretics for their fever. Maybe antihistamines for their rash if they're itching. Good nutrition, as much as you can get in them, so that you're building up their strength. Okay? So supportive care is an important part of caring for any of these patients. And again, if somebody comes in, they're they're malnourished already, they're dehydrated already, then you're already in a real negative case. Okay, keep going. Enteric fever, I saw this. So we had 2 patients with enteric fever. I had one young man that I taught how to evangelize. Part of my work, in addition to working at the hospital, was to teach a group of young men how to share the gospel, and we would go to people's homes and patients in the hospital, and we would share, and it was a wonderful time with them. He said that he and 2 others of his friends were in the hospital together with typhoid fever. One on this side, one on that side. He's in the middle. They both died, and he was left. So typhoid fever is a very serious illness. And if you look at the case rate here, okay, lots of cases, and the death rate, thankfully, much less. So we still have a lot of it, and we have to treat it the right way. So what happens with typhoid fever? This is an enteric illness, fecal oral. People swallow the salmonella that causes it, and it causes some severe changes, ulcerations in the intestinal tract. Here are the symptoms. There's our old fun ones again: fever, headache, nausea, vomiting, cramps. So it looks like just about everything else. That's the challenge, but there are some additional things that can help us know that it's typhoid. Rose spots. okay? I think I've got a picture of them. I can't remember. Different changes in the lungs, splenomegaly, hepatomegaly, and relative bradycardia. So things that you can look for, a lot of abdominal tenderness. So again, remember the ulcers are in the stomach, they can vomit blood, they're obviously going to be losing blood, same old, they're going to have fever, and they're going to have spots. Go ahead. So this is the typical pattern of enteric fever. So here's 28 days of illness. So long. And there's the fever curve. So up there to 40, sticks at 40 for a couple of weeks, comes back down, okay? And in the middle, we're getting headache, epistaxis, nose bleeding, then abdominal distension, diarrhea, and here's where your complications come in. The Weidel test isn't as widely used as it used to be because it doesn't become positive until way into the illness. So blood cultures are a real important way of making a diagnosis. Yeah. So here's the gold standard: blood, stool, putting a string down into the duodenum, and here are different tests in different countries. We can go on. All right, so unfortunately there are drug-resistant Salmonella typhi, and that's just from several years ago. So you got some multi-resistant strains out there in different countries. So isn't that Nigeria? I thought it was. Yeah, and where's Ghana? Yeah, sorry, I've been in Nigeria, never been to Ghana. Okay, yeah, so we're right in the best spot there to have drug resistance. Go ahead. So what do we treat them with? This is the drug to remember, okay? Fluoroquinolones. That's the best stuff out there. When you have small children, even small children, I would treat with fluoroquinolones. But azithromycin is another option, and ceftriaxone. So those are big drugs that are used in typhoid, and here's your milligrams and how long they're treated. So, great. Prevention, back to the same thing. This is fecal oral. So water, sanitation, washing your hands, and vaccination. Okay, you can get it here. I've gotten typhoid vaccine in Ukraine before, or did I get it in Moscow? Can't remember. Before I went to Africa. So it only lasts for 2 years. If you have the opportunity to get vaccinated, it's a great thing to be able to do, especially if you're going to Nigeria where they have multi-drug resistance. Yeah. Okay, so let's go on to a fever that you may not know as well, chikungunya. I don't know if I can even say that right. Yeah, stoop walk, in other words, sick person. Go ahead. So this is another illness, viral illness that's transmitted by mosquitoes. And to be honest, I can't see where that is, so I can't imagine that you could either. Go ahead. That one didn't show up very well. Looks very familiar. Abrupt onset of fever and malaise. Okay. Fever can be up to 40, lasts 3 to 5 days. How do I know that this is the other, how do I know what this is? How can I distinguish it from dengue? Can I distinguish it from something else? Well, this illness has some real specific polymyalgias, okay? Most people tend to have, polyarthralgias. Most people get myalgias with malaria, with dengue, but these patients get arthralgias, and they last a long time. Some patients actually have sore joints for years after the illness, but certainly for months, okay? So this is one thing that you can remember, that they tend to have something like an arthritis. Okay, there are also skin manifestations, and we can see those on the next slide. And then we get that same old fun stuff. lymphadenopathy, thrombocytopenia, lymphocytopenia, like I said. Satan doesn't know anything new. He does all that. So this is a Filiform rash. He's got this spotted rash over here and spotted rash over here. Palms tend to desquamate, so there's rash on the palms. Yeah, so it looks different from Salmonella typhi. We didn't get to look at those row spots. I forgot to put that one in. All right, and like I said, they can have persistent rheumatologic signs in there, and new onset rainout phenomena in up to 20% of cases. So chikungunya fever, remember polyarthralgias. That'll help you to know what this is. Next slide. Most cases are self-limited, but severe complications and death occur, especially in patients that are older than 65 and people that have underlying medical problems. Same kind of decompensation, same kind of needs for vigorous supportive care, maybe even for intubation, for medications to to improve the vascular system, the heart, and everything else. Okay, and then you can see meningitis with this patient. So you're not going to get meningitis very often at all with malaria, less with dengue. You're going to see it with this illness here. Okay, the serology, back to looking for antibodies. That's the thing somebody needs to look for. Viral cultures, and supportive care. Back to that same old idea. So if people who are being treated for chikungunya are in the hospital, you want to try and keep the mosquitoes away from them so that they don't give the illness, the virus, to somebody else, because this is a virus that can be transmitted. All right, so some people have tried ribavirin and interferon, but we really don't have a good treatment for any of these people except for supportive care. All right, let's talk a little bit more about the combination. Again, they look alike, dengue and chikungunya, but polyarthralgia is your key. Almost all cases of chikungunya have it, and dengue fever does not usually. And dengue is much more likely to have this hematologic leukocytes, leukopenia, neutropenia, and thrombocytopenia. All right, getting down there. Yellow fever. Has anybody ever seen a case of yellow fever? Have you ever had family members that had yellow fever? Okay, I know you've all had to have yellow fever vaccinations. Yes, your yellow fever, to come here, I'm sure that you have them. So it's an acute viral hemorrhagic disease transmitted by a mosquito. Sound familiar? Yeah. Just a different mosquito, a different virus, but a lot of the same symptoms. Next slide. So 50% of the cases develop severe disease, and case fatality rates can be up to 50%. Like I mentioned, there's a lot of classic epidemics in the history books. When they were trying to build the Panama Canal, it almost ground to a halt because of yellow fever. So yellow fever has been something that's come and wiped out large amounts of the population. So there are different zones. Here are your zones. Nigeria's in them. Okay, Ghana. Yeah. And you've got that lovely mosquito there. 34 countries are endemic for yellow fever. Go ahead. All right, so there's people with their vaccination cards. You guys have, I've got a card that looks just like that, little yellow card. I've been vaccinated for yellow fever now 3 times. I'm not sure. I went to Guatemala when I was a teenager, got it then. Then I got it maybe just twice. I've been vaccinated for yellow fever. Over 100 million in West Africa were vaccinated, but this has not happened in Central and East Africa. So as of when this slide was made. So vaccine is the big challenge. Urbanization, low levels of population immunity, lots of mosquitoes around. So it's still possible that yellow fever outbreaks can occur. So yeah, go ahead and take that on, and it can spread. There we go. It's spreading all over the world from different places. So what do we do about yellow fever? We look for it 3 to 6 days after exposure. So this is the incubation period. People can be quarantined when they've been in an area if they haven't been vaccinated. Same sort of symptoms: high fever up to 40, chills, headache, muscle aches, nausea. Sounds familiar. And either they go into remission in about 6 to 9 days, or, next slide please, they go on to be really ill. So you see a pattern? I mean, just very, very commonly, this is what you're looking at. So either you go through a crisis, the patient gets better, or if they're immune compromised, if they're young, if they're malnourished, if they're already in a bad state, susceptible, then those people can go on to have serious illness, and all of the things that go along with it. Delirium and seizures, I don't think are very common outside of yellow fever, but you're not going to want to wait to make your diagnosis of yellow fever when they start having seizures. So, and what do we treat it with? Supportive care. So there's no good treatment for yellow fever, just supportive care. That's why vaccination is so important. So if you can get vaccinated from anything that is in your area that kills, then do it. Obviously, yellow fever is a required vaccination for travel, but typhoid is not. It's a real good thing to do. Okay, so Ebola, 2 minutes on Ebola. I don't want to be, I would love to talk to people who experienced the situation with Ebola or with your family members. We grieved and prayed for people when the epidemics were going on. There was an epidemic of Ebola in my part of Uganda before I went there. And so you've got all these symptoms that start mainly in the gastrointestinal area. Again, fever, chills, myalgias, and malaise. Lots of gastrointestinal symptoms, along with very, very serious chest pain, shortness of breath, cerebral edema, seizures, and more hemorrhagic. There we are. Petechiae, ecchymoses, bruising, oozing. So again, fever, fatigue, vomiting, diarrhea. So most of the time, these people are diagnosed because there's an epidemic and because it's already happening. They've been in contact with somebody, and all this starts. So people who are going to die usually die between days 6 to 16 of complications, around a week. And the people, again, they turn the corner around day 6. The case fatality rate about 71%. So this is thankfully something that's been contained, but continues to break out at times. And we hear a whole lot about it because it's very frightening, but it's not near the cause of death that malaria is, or some of the other illnesses we're talking about. So it's tough at first to diagnose it because, again, the symptoms aren't specific. But if they've been in contact with Ebola, then there we are. And here are the tests for it. Pretty similar to some of the other illnesses we've been looking at. Here's the clinical progression. We talked about it. Later stages, and these are the patients who recover. So here are all the, again, hemorrhagic, shock, convulsions, chest pain, confusion, and the people who pass away. All right, there's no approved treatment for Ebola. We heard that before? Yeah, so that's what we're looking at with tropical diseases. We're looking at something that, again, and here's the supportive care we were talking about. Volume retention, maintaining blood pressure with vasopressors if needed, maintaining oxygenation, controlling pain, supporting nutrition, treating secondary bacterial infections. Okay? So that's supportive care. That's what we want to be doing for all our patients, and still looking for good treatments for Ebola. All All right, I think we're almost to the end. About 5 minutes. I'm going to talk about schistosomiasis. I've got a lot of pictures of other things. I don't know if we're going to get to those. That's okay. So schistosomiasis is a very important infection that you need to know about. Okay. Some people call it Bilharzia, and it's been around for years. They found it in mummies. Okay. But the first time that it was ever described was in the 1800s. You can see schistosomiasis, different species. Go ahead. Yeah, and different geographical distributions. So schistosomiasis mansoni and intercalatum and hematobium, more in Africa. And who gets it? People in contact with infested waters. Women washing clothes, children, all the things I saw. Farmers when I was in Uganda. All right, so where is it? It's in a lot of different places. Areas where schistosomiasis is a public health problem and helminthic exec, it's all over in Africa. All right. So what the symptoms are caused by the body's reactions to the worms themselves, not the worms. So you got a lot of people who have chronic schistosomiasis infections. Like I said before, this is the third largest killer. 800,000 people die of schistosomiasis in Africa every year. So this is a very serious problem. I have a friend who I graduated from medical school with, and one of his life's works has been to try and eliminate schistosomiasis. He has been in Africa many, many times, working with public health departments to try and prevent and treat this illness. So what kinds of symptoms? Abdominal pain, hematuria, the big one. It attacks the bladder and the renal system, and as well as the GI, the GU system. So you get vaginal bleeding and infertility. So it's it's an infection of young people. So children get it, they're not treated, and then they go on to the infertile. So how do we find it? Yay, get to look at something other than serology, yes? Looking at fecal urine samples, looking at for the eggs in the stool. So there's the ugly thing itself. And it burrows into the human host skin and goes on to live in the blood vessels and then deposits thousands or millions of eggs. The story of helminths is always very, very nasty. Yeah, so here's a picture. Here the Cercariae in the water, okay, multiplying in snails, and then going into the skin, and on they go. Migrating to the portal system, maturing into adults, and then again going into the bladder and the female organs. All right, so obviously, in addition to chronic cases that cause infertility, you have acute illness that is fatal. So what do we treat these people with? Yay, there's a medicine. There's a medicine, Praziquantel. Okay, so it's cheap and it's safe and it's effective, and it can be used in childhood. Okay. So that's one illness that I want you to think about and look for in your community. Read about it, learn about it. Schistosomiasis. It's a real problem in Africa, and we can make a difference. So the last, just got a couple of minutes. You can take a few pictures if you want. So dermatological manifestations of tropical diseases. Everybody loves to put these slides in their talks. They're always gooey and yucky. So the next slide, so we'll just kind of go through them. We can pass this up and just kind of look at some of the pictures. So this is scrub typhus. These are eschars that are from the rickettsia going under the skin. Go on. Yeah. This is trypanosomiasis. through the bite of the tsetse fly. You may know this one. Go on. Here's a picture of the trypanosomyces in the blood. This is swimmer's itch. This is similar to the schistosomes. It again comes from the water, but these are non-human, so they don't go into the body, but they do cause a rash, very itchy rash. This is sea bather's itch. People can get that here, jellyfish off the Black Sea. I've seen a lot of them, and they cause inflammatory papules in areas under the bathing suit. So, yeah, go ahead. Enterophiliasis, never seen, don't know much about it, looks pretty yucky to me. Cutaneous, sitting there under the skin or in the lungs. Cysticercosis, here you've got larvae again in the muscle, okay, or subcutaneously, and you can see pictures of them. Yeah. Leishmaniasis, another important infection transmitted by sandflies. You've got different sorts of clinical syndromes. Go ahead. I can't remember if we've got a picture of them. Again, that's another endemic illness that's all over the place. And patients have non-healing cutaneous lesions. From weeks to months, they can be incubating. It starts as a papule, goes to a nodule, goes to an ulceration, and is slowly progressive. So it's a infection. Usually has a rolled edge to it. I think we've got a picture of those. So yeah, there we go. See them? Right here, rolled edge. Okay. There's some over there, here. So remember it said you go from a papule to an ulceration. So here's different stages of leishmaniasis. Okay. Diagnosis, treatment. You can do topical treatment. You can do cryotherapy. Or you can go for the big guns if they've got lots of, and it's inside amphotericin. Go ahead. Cutaneous larvomicrons. I think this is always one of the ones that I thought looked horrible. Go ahead and show it. So, yeah, there's the worm under the skin. There's the worm itself. There's the path. Those can live a long time, way too long in my mind. Strongyloides, another parasitic infection. You probably remember that eosinophilia is a big marker for parasites. So you do a blood count, and they have a lot of eosinophilia. They're from a place where they have exposure to dirt and fecal oral routes. They can have parasites. Yeah, Loa. This is the one that can live for longer than 10 years. What a joy. Here's a yucky picture of this one, I think. Next picture, yeah. There it is, sitting in the eye. All right, sorry. Yeah, going on. Okay. Anthistomiasis isn't in Africa, so we can pass that one. Yeah, myiasis, little larvae that burrow into the skin. Patients have persistent moles, so you need to remember that these can be actual larvae living in the skin. Next picture, we can see that one. Yeah, so there it is. There's the larvae. There's the hole where they're sitting. Yeah, I think Tungiasis, don't know anything about this one, little flea that burrows into the skin again. Don't know him. It's a blessing. It's an incredible privilege for us as medical professionals to prepare and train and minister in any part of the world. And I just pray for God's richest blessings on you. Maybe we can do that again one last time. Let's pray and ask God to empower you to be able to distinguish tropical illnesses, to be able to treat them adequately, that people under your care would survive, that miraculous things would happen in your practice when you're there. And Father, we just thank you. Thank you that you're a God, and I believe that you gave doctors authority over illness, and I will pray for authority in Jesus' name for each one of these medical personnel. pray for authority over dengue, over malaria, Father, over typhoid, over yellow fever, over Cysticercosis, Father, over all the different infections, all the different parasites that would come against their patients. And Father, I just pray that you give them wisdom, ability, Lord, and you continue to empower them to, day after day, do what they need to do to be empowered by you and filled by you and given peace by you and joy, Lord, that they never wear out, that they'd be able to do all those things. We thank you for it. In Jesus' name.
Amen.